Hello, and welcome to today's Bipartisan Policy Center program addressing possible responses to the shortage in the mental health and substance abuse workforce. I'm Marilyn Serafini, and I direct the Health Project here at BPC. Even before the COVID pandemic, the unmet need for mental health and substance abuse treatment was significant. In 2019, 52 million adults had a mental health condition, 19 million had substance use disorder, and 10 million had both. However, that year, more than half of adults with a mental health condition did not get treatment. Nearly 90% of people with substance use disorder didn't get treatment. As you can imagine, the pandemic made all of this worse, with more drug overdose deaths, aggravation of existing mental health problems, and new anxiety and depression. So why are so many people going without treatment? A major reason is a shortage of behavioral health specialists, psychiatrists, psychologists, clinical social workers. And many of those who exist don't participate in insurance networks. That makes it difficult for many people to get help unless they have the means to pay most of the out-of-pocket cost. At the end of March, a BPC task force headed by Patrick Kennedy, former Congressman, former Senator John Sununu, Sheila Burke, and Richard Frank, released a major report with recommendations to help address this problem through behavioral health integration. The idea is to provide the necessary incentives and supports to enable primary care providers to handle more mild to moderate behavioral health conditions. Already, and we know this from a poll that we conducted, nearly 40% of adults receiving behavioral health treatment, that's for both mental health and substance use, get that help from their primary care provider. That's 40% almost. Today, with the generous support of Wellbeing Trust and the Sunflower Foundation, BPC begins building on that work to focus specifically on the behavioral health workforce. And here we're talking both about the licensed workforce, the clinical specialists, and also those who are unlicensed. And we're going to fully explain what we're talking about there. I'm going to turn the program over to Ben Miller. He's president of Wellbeing Trust, and Anita Burgos, who is Senior Health Policy Advisor to Congresswoman Robin Kelly. We're also proud to call Anita a former colleague here at BPC. Together, Ben and Anita wrote a paper recently that examines these workforce issues and lays out options for positive movement forward. You can find links to their paper and also to our report on our website, that's bipartisanpolicy.org, and also in the YouTube chat. After we hear from them, we'll have a panel discussion with former Surgeon General Regina Benjamin, Karis Myrick, who directs the JED Foundation and is also co-director of the Mental Health Strategic Impact Initiative, and Shekhar Saxena. He's professor of the practice of global mental health at Harvard's T.H. Chan School of Public Health. At any time during this program, we invite you to send us your questions, either through the live chat on YouTube or on Twitter using the hashtag BPCLive. So now I'll go ahead and turn the program over to Ben and Anita.
Marilyn, and thanks to the rest of the BPC team for our time today and organizing us. On behalf of Wellbeing Trust, it's wonderful again to partner with our friends at BPC to go deep on issues of mental health and policy. And what a day to be holding a conversation on workforce. It's a day where a major children's advocacy organizations declared a mental health crisis for our youth. A day where the White House put out a fact sheet on improving access for youth mental health and substance use conditions, or even a week when the CDC recently added mental illness as an underlying medical condition, which was associated with higher risk for severe COVID-19. Mental health is a topic we must embrace and do meaningful work around, which is why today's topic matters so much. Today's topic is one that is simply impossible to ignore in any meaningful health policy discussion, especially in light of current events, as Marilyn outlined. Without addressing our workforce, we will continue to ask questions like, who is going to do the work? How can we expand services if there's no workforce there to hire? Who are they? Where are they? What are they doing? And how do we pay them? A robust workforce positioned to be in the places that people are is entirely necessary for us to begin to address our community's broader demands for mental health and addiction care. We will simply fail without a thoughtful strategy on workforce. And as you will hear today, we know the problems with our workforce are indeed significant. And the impact is felt daily by millions of people. Marilyn outlined these stats already, but we know from studies only about 1 in 10 people with a substance use disorder receive recommended treatment, and about half of those with an identified mental illness get care. And we don't need more studies on the reasons for this. There are several, including things like health insurance benefits, cost of care. For example, in one survey from Kaiser Family Foundation, almost 40% of American adults delayed accessing healthcare because of concerns about cost. And another 4 in 10 adults with insurance said they have trouble affording their deductible. It's headline after headline, study after study confirming the same thing on mental health. We don't have enough clinicians to currently meet the demand. 33% of individuals who seek care wait more than a week to access a mental health clinician, some are upwards of 6 weeks or longer. 50% of folks drive more than 1 hour round trip to a mental health treatment location. And we know that the distance is problematic, as the longer you drive, the larger the health disparities can become. And perhaps to no one's surprise, 50% of the counties in the United States have no psychiatrist in them. And while these statistics are indeed daunting and a true sign of the times, they most often only focus on finding or identifying a clinician. Once you get into care, you face other barriers. For example, mental health office visits with a therapist are 5 times as likely to be out of network compared to non-mental health office visits. Or what about your clinicians not talking to each other, not coordinating care? Or what happens if the quality of care is lackluster? And I could go on and I could go on. So why are there such shortages? The literature highlights several themes, which I'll not go into too much detail on today. But here are some of the bigger ones. The aging of our workforce. Looking at low salaries that discourage the always present loan to income issue. A general lack of resources to support mental health clinicians as they do their job. All of this leads to fewer people entering the profession and patients having a harder time getting care. But let me go to a larger point that Dr. Burgos and I will address today. Our workforce is rarely in the places that we need them. And simply aiming to have more clinicians in clinics is not necessarily a winning proposition, though that's a strategy that we most often pursue in public policy. Our workforce is in serious need of a redesign, and it begins with these questions. What is happening, where, to who, and how? These questions should be a filter of sorts for any of our workforce initiatives and for our work in health policy. So I want to posit today that we may be asking the wrong questions about workforce. It may be less about how to get more and more about how to use who we have differently, including broadening our understanding of who the workforce actually is. We have a moment to begin to think about a new strategy for addressing community need. This is a workforce that could emerge in community, by community, and for community. So before I turn it over to Dr. Burgos, I just want you to ask yourself this question. What would you do to address the workforce problem? How would you solve this maldistribution issue that is so pervasive? How would you address the disparities in communities where there is no workforce? These are hard questions, but those that I think we're going to be able to address today. So Anita, I will turn it to you.
Thanks, Dr. Miller, for doing such a good job of outlining what the problem is. I want to walk everyone here today through the framework that we outline in our paper that really builds upon the work of academics in the field. The main point we want to highlight here is that mental health falls in a continuum, and there are segments of the current health workforce, particularly community-based workers, and even the lay public that remain largely untapped when it comes to addressing mental health and addiction needs. Where individuals fall in the continuum depends on their willingness to seek services, their healthcare insurance, and the severity of need. Although this is a pyramid that we're all looking at here today, it's not meant to imply a hierarchy. We don't want to give the indication that individuals with serious mental illness can only receive services or should only receive services at the top tier of this pyramid, or that individuals with mild anxiety are best served at the bottom of the pyramid. These services often complement each other. So at the top of the pyramid, we have services that we believe should be used with less frequency, in part because they're also the most costly to the system and require the most training for providers to provide these services. So at the top of the pyramid, we have services like specialty care and long-term stay facilities. The next tier includes more medium-term care, such as mental health and addiction services in general hospitals and community mental health care services, such as rehabilitation centers and mobile crisis services. But what we really focus on in the paper is the tiers that sort of follow those top two. The next few tiers really are where the most dramatic shifts need to take place in order to shift mental health and addiction care from high use of specialty services towards community and primary care. So the first shift that we identify in the paper that would require the increased integration of mental health and addiction services into primary care, where many folks are already going to receive care for these issues. However, we need to provide the financial support and an interdisciplinary team for primary care to better screen for and treat mental health and addiction issues. While I was at BPC, I'm really proud that I got to work on a comprehensive report on integrated care, which outlined tons of federal policy recommendations to move our health system closer towards integrated care. And Dr. Benjamin will speak to that a little bit more later in the panel, as she was one of the task force members of the Behavioral Health Integration Task Force. The second shift would require shifting more services to peers and non-traditional community workers. These include community health workers and promotoras, who already have established relationships with folks in the community and often provide services like health education, case management, and interpretation services. For community health workers and promotoras, there would need to be additional training in how to identify and provide interventions for mental health and addiction needs, whereas peer support specialists require some training as well, but can really pull from those lived experiences. This workforce can either work in parallel or integrated within a clinical workforce. The community-based workforce can also really contribute that cultural competency and that language accessibility piece that is often difficult to incorporate into clinical settings. And so as for the final shift, I would like to turn it back to Dr. Miller, who's really passionate about this issue, to discuss how to shift to more community-initiated care that centers on educating the lay public. And this is the sort of the last tier in the pyramid.
Thank you, Dr. Burgos. I think based on the literature and a review of what's happening across the world, this last category here, community-initiated care, is one of the most radical and potentially impactful ideas to address our nation's mental health crisis. Community-initiated care is based on this concept commonly cited in the literature as task sharing or task shifting, which is a way to say, how do you take an intervention that shifts a task from one place to another or from one person to another? This could be something that allows for the possibility for individuals who are non-specialized, trained healthcare workers, or even just lay members of the community to become interventionists themselves. As we wrote about in the paper, and as a member of our panel here will likely discuss today, community-initiated care is understood to be a broadly inclusive concept that democratizes knowledge and empowers communities to learn how to respond to mental health and addiction issues and to take helpful action in that moment. So it's really to create more interventional opportunities. Effective community-initiated care efforts should really involve training and supporting community members to ensure that they acquire the knowledge, the skills, the competencies necessary to deliver these high-quality, evidence-informed interventions that are out there. There's such promise in this approach, where mental health promotion, prevention, and low-intensity interventions can be delivered by a range of people within our communities. Think about what happens if barbers or beauticians or teachers or faith-based or spiritual leaders, community health workers, and the like are trained to do more mental health interventions. Imagine what would happen in this nation. If the premise is that we will never have enough clinicians, shouldn't we start to think about how we get creative now, today? This is our moment to pursue novel solutions to complex problems. And the framework that we've laid out for you today, we hope can be used by policymakers to rethink our general approach to workforce rather than just we need more. But why this discussion today matters is because we need a federal policy plan and recommendations to help us more broadly pursue workforce solutions that can meet the needs of our community. Thank you so much for joining us and for helping us rethink the mental health and addiction workforce. Marilyn, back to you.
Great. Thank you so much, Ben and Anita, for laying that foundation for us. So we're going to talk today with our panelists about all of the areas that they just mentioned. And we're going to start with behavioral health integration. Dr. Benjamin You are a member of BPC's Behavioral Health Integration Task Force, which produced the report in March. And how can integration address the workforce shortage? And how can we enable primary care providers to take on more mild to moderate behavioral health conditions? What is it going to take to get us there?
As you mentioned in the beginning, that the mental health and behavioral health issues have been going on for years, but COVID-19 made it much more prevalent, much worse, and over half the adults had a problem in 2020. Our healthcare system does not have the capacity to handle that much of an increase in behavioral health services. So coming together with the primary care and behavioral health sciences in the same place will help us address it in the immediate future, because it'll take a long time for us to train enough people to get there. It also has other advantages. There are no silos. Our offices are the same offices. The stigma is less. We can have the consults that are right there, and it'll relieve a lot of that anxiety and depression that happens in stress when people don't want to go to a mental health facility. I get that all the time. People will, I don't want to go to a mental health facility. I'm just having little problems. And one of the things we recommend is that we establish those services, but we also train and diversify our workforce and start to look at how we can support primary care offices with technology and other things that we can talk about more. But in particular, as we move to value-based health system payment, that this is included. Many of the primary care doctors or clinicians particularly don't feel comfortable in treating some of their patients after a certain point. But if we can give them some training, give them some support, that's really all we would need. We want to do well. We want to take care of our patients. And so increasing funding for education programs is also another way we talked about. And as we talk about all of these things together, I think this will make us a stronger healthcare system and dealing with the things that patients have every single day.
Yeah, and one of the ideas that the task force focused on was getting primary care providers access to consultations from behavioral health specialists, which would be really a good use of their time to enable the care to remain with the primary care provider, as opposed to referrals, which would take more time from the behavioral health specialists.
And particularly if we could have a statewide program, a program that was easy to integrate, we didn't have to jump through hoops, that is seamless. And that's one of the things we're proposing through the paper.
Right. So, Dr. Benjamin, let's talk about children for a moment. Children have been affected greatly during the pandemic. So we know there's a shortage of providers for adults. What does this look like for children, and how are children affected?
Children typically are resilient, but they can only be so resilient. And we really have to pay attention and listen to them very carefully and closely. Parents and family members and friends, pay attention to what they're saying and what they're doing and their actions, how they change. It's really starting to affect children more and more. And we see that in not by the time their grades and things start dropping, it's late, but we see it in just the way they're playing, where they're smiling and having, interacting or moving to themselves. So it's so important that we do that. But that's part of when they go to their primary care and have their appointments, that we start to look and ask children of things that same way. The kids, for me, when they come to my office, they'll tell you things that they wouldn't tell their parents. And so at the clinician's level, even at my nurse practitioner or my physician assistant, they'll talk to them, give them some time. But paying that close attention, we tend to want to check off the boxes with the medical part, but the behavioral part is so important.
Okay, so let's move to the community education piece of this. Shekhar, can you please talk to us about what Ben and Anita brought up regarding training communities and equipping them with the skills to address mental health needs in the community? Tell us more about this idea and how it would work and what we know about it already.
Thank you, Marilyn, for inviting me. I'll take a step back and tell you about the public health principle, especially as applied to mental health. And here I'm making a difference between mental health and mental disorders, which are not the same. Mental health is about all of us and not about some people who have a disorder. It's an essential attribute for all of us, and we are somewhere on the dimension of mental health, coping very well or sometimes coping not so well, to having a symptom, to having a disorder and disability. And if we take that dimensional approach of mental health, then it has to do with the community and it has to do with non-clinical care by other people besides clinicians. And the second principle of public health is that promotion and prevention are extremely important besides treatment. Of course, some people will require treatment, but a lot can be done and should be done for promoting people's mental health and preventing disorders from developing. And combining these two principles, it's very clear that communities have to play a major role. And community-based people, as Dr. Miller explained, community-initiated care can be actually a solution to not only providing the care for people who still don't have a disorder, sometimes adding on to people who have a disorder, but also to prevent the disorder so that the actual load on the clinicians will decrease. Now, who are the people we're talking about? We're talking about community health workers who are very common in other countries, not so much in US. Also taking the example of people who are social workers or other people who are involved in the community like teachers, even barbers, as Dr. Miller said. And if these people can be trained to provide simple solutions to problems which have not really progressed to the extent of a disorder, we will actually be doing a lot of benefit. I worked in the World Health Organization for 20 years before I joined Harvard, and I have tried to assist a number of countries in developing that kind of workforce, especially because the number of psychiatrists and psychologists there is extremely limited. So it's not only desired, but it's an absolute need there. And with major successes. So you think about lady health visitors in Pakistan, you talk about ASHA workers in India, you talk about social workers based in the community in Sri Lanka. They're all doing marvelous work, and they're promoting health and they're promoting mental health and preventing mental disorders. And of course, for people who have a disorder, providing the most basic care, which actually helps a lot. So I would say by any concept of public health and also dictated by the realities, community-initiated care is absolutely necessary, as much in USA as in Sri Lanka.
What does the training look like? How do you envision this? What kind of training would a person need to go through to be more equipped in the community?
It has to be focused and has to be clearly directed towards the roles that we would like them to perform. So I'm not talking about training on diagnoses. I'm talking about training about the people's needs and how mental health has to be looked after by themselves, like self-care, and also by counseling and simple advice. And there are many manuals available. The training to an educated person, for example, a school educated or college educated person, will be about 2 weeks for the majority of mental health problems. And that is really sufficient for them to play a major role. We are not making them doctors. We are not even making them nurses. We are making them mental health promoters and lay counselors. And that really helps. Of course, for doctors and nurses who are part of health system, the training has to be more and has to be much more clinically oriented, so they can actually help them in the health facility where they work and lastly, very important, which was mentioned also earlier, supervision and support is absolutely necessary. If you just train people and leave them, not much happens. So a clear systemic approach to provide support and to provide periodic supervision is absolutely necessary. But believe me, it really works.
So you just mentioned the word peer. So that's my cue to turn this over to Karis Myrick, who can talk to us about peer support specialists and what their role is. So we're talking about, Ben and Anita touched on peer support specialists, community health workers, and promotores. Karis, can you help first by helping us to understand what each of those is and how they can be a part of this, a part of the solution, and how they already are being a part of the solution?
Yeah, sure. So first of all, thank you for inviting me to come and speak with everyone today. This is always exciting to talk about workforce issues, especially when people want to include peers. Yay. So let's talk about peers. So peers are people with lived experience of a mental health condition that, along with some training, provide social support and other types of support to people that they serve. It can be people who are within community mental health settings. It can be people who are in hospitals. Some peers serve in criminal justice settings and forensic settings, and then also in the community. So peers can be across the spectrum of care, if you will, or continuum of care. And peers in mental health are generally called peer supporters. Peers in substance use generally call themselves recovery coaches. We also have peers that are family members and parents. So it's kind of cool. You get the whole family and you get both the spectrum for behavioral health. And then community health workers are a little bit different than peers in the sense that community health workers tend to have an affinity with the community in which they're serving. So their primary affinity may not be having a mental health condition. They don't need to have a mental health condition. They just need to have some affinity with the community in which they're serving because they're seen as sometimes a cultural broker or community broker that's trusted by that community. So Shakar and Ben and I think Anita were talking about barbers. You know, barbers are trusted in the Black community. I go to my hairdresser, I'm there all dang day. So, and this is how Black women do their hair. So when we're in the salon, wouldn't it be cool if the beautician were able to support somebody while they're getting their hair done? That's kind of cool if they kind of notice something and have that training. And then promotoras or promotores, if you're considering both men and women, are also health promoters in the community. It's a model in which there is a cultural affinity to the people that you're serving, and they are health promoters doing primarily prevention work and support work, connecting people to services should they need those services. So you have this whole array of folks who we really need at the table and providing services for folks that need.
Karis, how much are they already at the table, and do we pay them?
Yeah, well, let's talk about that. So actually there are 49 states, California being one of the last, but we're there, I'm in California, that have certified peer specialists. And CMS in 2007 wrote a letter to the states indicating that you can have a certificate, you need to have a certification process, a training process, as well as a supervision process in place approved by CMS in order for states to bill Medicaid. So there are 49 states that have the certification process, and probably about, I can't remember if it's 41 or 43 states that are actually billing Medicaid, and this is on mental health, and it's fewer states billing on substance use. So there are peers throughout, as I said, in forensic setting, hospital settings, community mental health, and CBOs, peer-run organizations. Or a lot of people are familiar with like NAMI, National Alliance on Mental Illness. They also have things like family support and parent support groups that's not paid. The other types of peer support are paid. Promotoras in general I think it depends on the area. Sometimes they are paid and they can be a part of the system. So where I am in Los Angeles County, promotoras actually work both in public health and they work in mental health. We also have community health workers that work both in public health and also mental health. But in general, there is, I think, for certified peer specialists, requirements from CMS in order to be able to get the reimbursement. If you're not going to do the reimbursement, there are different ways in which the workforce can be paid. And some people do volunteer, but that's generally because they want to do the volunteer, not because they shouldn't be paid or couldn't be paid. Are all paid a living wage? Do you really want me to answer that question? No. And I think that's where we could really do much better. And then lastly, I will say, as far as integrated care, we really want to increase opportunities for particularly peers to be able to work in integrated care, which they can. And there is a bill that actually clarifies that peers can work in integrated care settings with primary care and so forth, because they can also augment that workforce and help with the people who are being seen in primary care.
So we've talked about a number of different approaches here, and we have Catherine on YouTube asking about strategies for expanding children's mental health workforce. What are of the different kinds of folks we've discussed? Can some of them help with children, and what are the answers for children? And I'll throw that out to anybody.
So
I think school is the right place for children, and teachers can be trained, and they can provide the initial screening as well as help to find children who are struggling. And if there is need, then they can refer them to specialists who may again be based in a school, because one of the most important part here is care without a stigma. And if a person is referred, as Dr. Benjamin was saying earlier, to a psychiatrist or a psychologist, it does lead to stigma. So care wherever it is possible, where the child is, which is school or communities, and care in an environment where something could be done without increasing the stigma which might get attached. That's, I think, something that we must look at.
Mm-hmm.
Yeah, I was going to add that there are youth peer supporters. So that's one thing to think about, is the role of a youth who is trained to provide support to someone else who is a young person, because the person can see themselves. I mean, that's the cool thing about peer support, is you see yourself, or you can really feel more connected to somebody who's been through or is going through what you've been through. The other thing is, when I think of children's mental health, I also think of the family and the importance of supporting the family. One of the things that we found from research, especially around family supporters and parent supporters, is that families feel far more confident about how to help and how to support their young loved one. So family peer support and parent peer support is also another way to think about the array of provider types that could be helping children and children's mental health.
And I would also just kind of add to that with the family support. Oftentimes family have difficulty finding how to navigate the system. Things like attention deficit or any part of this issues that the kids will have. As primary care doctors, offices will give them a diagnosis and then they're stuck. What do they do and how do they get the support? And that's where bringing it all the way around, getting it back in the community is very challenging for parents, particularly.
So, Dr. Benjamin, how much do primary care providers know about peer supporters or some of these other options for them already?
Not enough. And as Karis was saying earlier about the peers, I find out a lot about my patients often in a grocery store. In a rural community, friends and stuff will tell me things about a patient, then I can follow up. It would be so much more helpful if it was more organized, if it was much more structured and in a way, and if it would provide jobs for patients and family members and friends, and in small towns we call them the busybodies, but they know everything and they help. They go check on people, they give them, bring them something to eat just to check on them, but they know better than I can ever know in a 5-minute visit. And so having them connected to me would be very, very helpful.
So Dr. Benjamin, you just mentioned a key word, and that's rural. And we know everything is harder in rural areas, that people are further from their providers. We know that so not only do they have to drive longer distances, but also when you live in a small town, when your car is parked outside the psychiatrist's office, that's often a deterrent to people seeking help. So do all of these approaches, can we work with peer supporters in rural areas? How much is the community education, how much of a help could that be in rural communities?
It's tremendously helpful in particularly in rural communities, but often, and I have to also say in large cities, sometimes people are isolated as well, but in rural communities, we don't have the numbers and the volumes. And so it may be helpful to have technology help us. And that's where we recommend that telehealth or video conferencing or even just telephone consults sometimes come into play. And I've seen that patients will often be okay doing a teleconference because they didn't have to go to a mental health facility and turning down some of that stigma. But as a clinician, I also need the help from the specialist for us to be trained on how and when we can use those services. So it's kind of circular. It's good for the patients, but it's also good if the clinicians can also get trained.
Okay, so now you mentioned another key word, and we're hearing this in some of our questions that are coming in. Telehealth. Telehealth became much more prominent during the pandemic. We saw a lot of people getting it. Of course, there are some barriers to receiving telehealth, such as people who don't have broadband access in rural areas and some other areas as well. Some people can't afford the equipment or the internet connection. And especially with some of our older population, there's also a concern about people having the digital literacy to be able to use telehealth. Now, there are virtual visits, but during the pandemic, we had some flexibility, and we also had some audio only or telephone visits. So I'd like to ask all of you about your thinking about how telehealth, and here I'm including audio services, how this fits into your thinking regarding the workforce.
I'll just start quickly and just say that all of those things are important and that we can't treat it as one single way of doing things. And it's not the solution, it's just part of it. It's another tool that we'll have. There are some people who only have smartphones, they don't have a landline. Whereas particularly in rural areas, some people didn't have a smartphone, they only had landlines. And if you only have a landline, you can't do a video call. And so taking into consideration each person's individual, it also, it's a new tool for me as a clinician to help, and it helps me tremendously. So I hope we don't go backwards, we go forward. Many of the behavioral health patients are comfortable with telehealth and telemedicine, working through it. So I hope we continue with it, and we'll work really hard to get people to, and particularly the payers, to understand that.
Karis, do we have a lot of peer supporters in rural areas, and can peer supporters help from it when we're talking about technology and telehealth?
Yeah, so I don't actually have the number of peers that are in rural areas, but we know that that there are peers there. I don't know, percentage of population or raw number. One of the things that peers were able to do during the pandemic is to switch easily and more quickly to using technology to have group meetings. They were already doing support meetings. They just switched, and I'll never forget seeing literally within the first month national meetings for people with substance use disorders to be able to continue to have their recovery support meetings, and just inviting anybody. It was like, look, we don't care if we get paid or not, or how. The bottom line is people can't be left without having access to their recovery support meetings. So the other thing is we became very, very quickly aware of who didn't have what, and trying to help people get access to, for example, the Lifeline program, but finding that the Lifeline program did not have certain waivers that needed to happen in order for people to be able to maximize their use of the technology they could get through the federal Lifeline program, which can get you access to the hardware as well as software. The other thing we had to be mindful of is that some people were stuck in environments that were very dangerous for them, meaning it could be they could be in a house with an abuser. So how do you have these discussions, and how do you find places to get the support you need if you're in a house where you can't use the phone or the video connection in order to get that support because it's not the safest environment for you? And same for children who were hesitant to speak openly when their parents are in the next room, right? So we do have to have a hybrid model. The last thing I think that peers were very, very helpful with, and again, we work very hard on this, is helping people with digital health literacy. So even though somebody may not have had the technology and we were able to get them the technology, they didn't have it, they didn't know how to use it. So it still became a barrier to connect people to using video or audio telehealth access and or support group access if they didn't know how to use the technology. So we were doing telehealth, we were doing digital literacy training for things as simple as, how do you turn on the computer? How do you get an email? Like, how do you set up an email? How do you access your EHR if you have a patient portal for your EHR? How do you use the platform for the telehealth? How do you think about security and privacy? People were loaning their phones to people, which then opened up everything to some random person you had let your phone to. So we had to help people think about their digital footprint and their privacy and security. So peers are excellent at that, because sometimes the providers will say, I don't have time to be able to help the person connect. I'm trying to learn how to connect myself. So this was really a fantastic.
Which gets to this very issue of telehealth. And she wants to know what role direct-to-consumer and telehealth only mental health providers play in alleviating workforce shortages. Are the vendor-based services helpful or harmful in the long term?
Could be both. There are all kinds of vendors. And also, just coming back to where we were, if you take the wider definition of digital mental health, it could also be the apps and the telephone lines and the internet-based assistants, which are becoming very commercialized now. So some of them are completely non-evidence based, and one has to really rely on the credible source for where one is going. And taking all of that into account, digital mental health can be a multiplier, but can also be a problem. So one has to really be very careful. And I think there is a need for some kind of regulation as well as licensing procedure. And payers are able to do that because they can define whose services we will pay and whose services we will not. So that some kind of order can be established. Otherwise, it seems to be in some cases a free-for-all. But also we can learn from some other countries, and especially some middle and low-income countries where, as I was saying earlier, the providers are very, very few. So digital mental health can actually be a great help, and it's happening. It's happening in Uganda, it's happening in Kenya, it's happening in Zimbabwe, which is one of the poorest countries here. And a lot of people are receiving help from digital means, either from individual providers or from some kind of automated systems. And of course, that's not the answer for everything, but it does help to scale up services.
Yeah.
I think that's also correct. There are a number of commercial companies out there that are really trying to help in this space, that are doing really good work in bringing together the services and connecting, doing the wraparound services, as we're calling, addressing the social determinants. Those things are very good, but I agree we need to try to find some type of way of certification or letting the public know when it's a good program. The other issue with this is that with the commercials, they're great, but what about the people who can't afford them? And so there's a whole population out there. And in my plea to these startups particularly is don't forget those folks who really don't have the funds or the access to it, to make sure they have some access to these services as well.
And I'll add that that I do think of digital telehealth is only one component of a larger array of services that can be accessed through technology if people have the technology to use them. And it is a bit of the wild, wild west out there right now, because there isn't a process to vet or to, I don't know, certify certain apps about whether or not do they do what they really say they do. So one of the things that the American Psychiatric Association has done is they have an evaluation tool, the APA app evaluation tool, that can help people think through different levels of decision-making, whether or not they want to use an app or recommend an app, or if you're a provider and you ask the person you're serving, well, what apps are you using, then actually you all can look at the evaluation tool together to see, oh, wow, yeah, this, maybe it doesn't have the best security, or look, it actually had some research behind it. And that's actually another thing that we teach in digital health literacy is how do you make wise decisions about what technology to use when you want to use various apps or different things on your computer or your phone to aid in your recovery. Oh, and I will say one other thing. We did find out, or well, not we, but it has been shown, and this is just initially, that young Black boys prefer to use telehealth to connect to their providers. And it may be because there's enough distance between them and their providers to not feel any sense of not wanting to connect, not wanting to be open, especially if that provider is not of the same race or culture as themselves. So I think there may be some opportunities to think about how do we look at telehealth, how do we look at technology across different cultures, and how people may use them to maximize its use versus thinking, as Dr. Benjamin was saying, it's one size fits all. It probably isn't one size fits all, but there are ways to actually maximize how we can use it for different populations.
Doug on YouTube submitted a question and a statement. He said every state should have a center focused on training and ongoing support, perhaps based in a medical center or even colleges. And he wants to know, could states use some of the opioid settlement funds to set these programs up? I'm going to broaden that question out a little bit to talk about what the federal and state role is in helping to promote all of the things that we have discussed today. So please, feel free to directly answer Doug's question about using the opioid settlement funds. But also, we're starting, we have about 10 more minutes in our time here together, but I'd like to, start asking you all, what is it that we need to do from the federal perspective? You can also talk about the state perspective. What is the role in making some of this happen? How do we do more of everything we're talking about? It's a hard question. Dr. Benjamin, can I put you on the spot?
Sure. We talked a little bit about developing a increased grant funding to statewide psychiatric consultation services. That would help primary care clinicians have access and smooth transition, because we don't really have that. And it may be in one town you have something, in another you don't, but if you had that consultation service set up, that would be good. Having the community health centers that are there, combining with the community behavioral health clinics, that they be on site together, and that having that, if we could get HRSA to support those and allow them to work together, because they're separated, and take away those silos. And those are really important things that we could do together. When we talk about, again, having value-based care and the way we reimburse payment system influence behavior. So if we would take that into consideration at the federal, particularly federal level, and how we reimburse, we would give the incentive to put the effort there. Because again, behavioral health and mental health parity as well with insurers.
Marilyn, I will just add that since this is a policy center, we would like to change the policy at the federal and state level to have better recognition of the need for community-initiated care, and then to direct the local authorities in using whichever funds are available to make that happen, because this does make a lot of sense. So we need to find solutions to that at all levels, at the federal level, but also at the local level.
Yeah, and I would add continued focus on peer support, which we've seen at the federal level. There are several bills in which peer support is named and embedded, and some in which they ought to be embedded, but they're not, around health and home and community-based services. There are lists of all the provider types, but peers are not within the list, which they need to be called out. Because if they're not called out, people may not think that some of the roles that peers play fall within home and community-based services. So anything to expand the workforce, as well as to understand who this workforce is. We're surmising that the peer workforce in particular mirrors the communities that they come from, which then again says something about the dearth of providers who are Black, Brown, and people of color. You may find a lot of them within the peer workforce, and we want to be able to expand that.
On primary care providers. And we do have a question, another question coming through on YouTube from Mandar. And it's a great question. What ideas do you have for protecting primary care providers from being overwhelmed with more integrated care while they continue to have to see patients every 15 minutes? So if they're going to take on more of the responsibility, is this even, how do we make sure that they are getting what they need so that they can actually do this?
There are a couple of things that we talked about in the paper, particularly around making primary care clinicians feel more comfortable by increasing their continuing education and increasing the funding for continuing education for clinicians. That's a first start. Also, we would make you feel more comfortable if you had that access to the remote psychiatrist and someone to bounce things off of. But in particular, providing technical assistance, helping to implement integrated care and transforming the practices really requires time. It also requires expertise and upfront investments. And the practices, while greatly different in structure and workflow, they really need help and assistance and technical assistance in that. So we ask for things like to assist with training and billing and financing, and even implementing the electronic health record technology, because it's different right now. You have two different electronic health records. And so increasing funding and support and technical assistance really would help.
So let's round out our conversation today with Karis. I'd like to know from you, what do we need to do? What is the one thing we should do immediately to really promote and to encourage the use of peer support specialists? And then I'm going to turn to Shekhar to round it out. What's the one thing we need to do to really get the ball rolling on community education? So let's start with Karis.
So I think a couple of things, but you said one thing. All right. So I think when we think about
You can do a couple, that's okay.
when we think about integrated care, I think of interdisciplinary teams and understanding the role of everybody on the team, especially that of the peer supporter, so that tasks and roles are actually within each scope of practice. So nobody's carrying the burden that they shouldn't be carrying. So I think there's going to need to be training so everybody understands each other's roles and they can work towards having the most effective care from each of the people who are on that team. Secondarily, I think, looking at current legislation like the PEERS Act, which actually clarifies that peers can be used within integrated behavioral health and a bill. So we're probably not actually maximizing the use of peers in that way.
Thank you. Shekhar?
I think we need to just remember that the needs of people for mental health as well as substance use and abuse and addiction problems vary a lot. Let's use the people that we have to really fulfill that need by involving them, by educating them, by training them, by supervising and supporting them over a period of time, which really adds a lot from the non-clinical perspective to the workforce that we should have. So let's convert what we have into the most effective method of using them for providing the kind of help that there is needed.
I'd like to just remind us that, what we're talking about, while severely mentally ill is important, we're talking about everyday stress of life. We're talking about prevention. We're talking about depression. And people who come in my office, I say, well, what are you here for? And they say, well, I'm here for my nerves. Well, I know what they mean. You know what they mean. We're talking about the overwhelming day-to-day living, the stresses of life. And so they need treatment. And so when we're talking about all of these things, this affects our overall health of the community, overall health of the person, from their blood pressure to their diabetes, whatever. But that's what we're talking about. And it is can be an overwhelming problem if we don't address it with our everyday lives. And so I think I just wanted to remind us that's really what we're talking about, and how do we address that in our healthcare system.
Thank you. So let's go ahead and wrap this up. I would encourage everybody who's listening to keep following this. BPC is going to continue working on these issues, and we'll be working on the approaches and finding federal solutions that can encourage growth in some of these areas and better use of some of these areas where we can help to make good use of our workforce. So I'd like to thank all of our panelists today for joining us, and also again for the partnership of Wellbeing Trust and also of Sunflower Foundation. Thank you very much. And again, you can find our report and the paper. You should have seen it in the YouTube chat, but also you can find it on our website, www.bipartisanpolicy.org. Thank you.
Thank you.